So I usually start the examination by asking the patient to show me where it hurts. Can you show me where it hurts with your finger? Okay. Do you have any pain in your leg?
No.
Not at all. Very good. Then the next part of the examination is really inspecting the back, looking in particular to the general alignment of the spine. Usually the shoulders should be level, like they are in this case, and the iliac crest as well. And one will look also for any lateral deviation of the spine, including more subtle signs such as asymmetry of the cutaneous folds, which could reflect scoliosis or the presence of muscle spasm. And any scars or bony deformities should be noticed as well. The next step is to observe the movements in flexion and in extension. And while you do this, you're really interested in looking into the rhythm of the movement. And normally during flexion, there should be a smooth reversal of the lumbar lordosis. So let's do this. Can you please bend forward? And we can see here that now the lordosis is flattened and slightly reversed, which is normal. And then I put my two fingers like this, which will help me to really assess if the movement was made at the lumbar level or at the hip and pelvis. So when you come back, you can see that the distance between my two fingers narrows, confirming that the movement is really occurring at the lumbar spine level. Now, if he was compensating and moving his back simply at the pelvis level with the help of knee flexion and hip flexion, there would be no narrowing of the distance between my two fingers. Following this, we do a screening test for significant weakness in the S1 and L5 distribution. We ask the patient to walk very high on his toes, which is a good test to assess for significant weakness of the muscles innervated by S1. Following this, we ask him to walk very high, but this time on his heels, which is a good screening test for significant weakness in the L5 distribution. And finally, asking the patient to squat down is a good overall test for proximal weakness, which could be a reflection of a radiculopathy higher up at the level of L2, L3, or L4, but it's also a good general test to test the integrity of the hips and knees. Can you now sit on the table? So in that phase of the examination, we will test the reflexes, the knee reflex, looking for asymmetry which could reflect an L4 radiculopathy, and the ankle reflexes which are innervated by S1. Now, if the reflexes are difficult to elicit, what you can do is a distraction maneuver by asking the patient to pull his hands. That will relax his muscles and should be a lot easier to elicit the reflexes. Now, while the patient is still sitting, a very important test to do is the straight leg or the modified straight leg test, which consists of simply elevating the leg, first this one and then the right one. Now, in a patient who has a radiculopathy, say of L5 or S1, when I do this, that increases the stretching of the nerve root, and as a response, as a natural response to that, the patient's trunk will move back, causing what we call the positive tripod sign. So why is this a good test? In a situation, for example, when a patient has a positive straight leg raising test in the supine position, one would expect, if this is due to an L5-S1 radiculopathy, to have a positive tripod test when he's sitting down. If you have a positive straight leg raising test lying down, but a negative tripod test in the sitting position, you should suspect the possibility of a non-organic pain. Can you now lie down on your back? So in this position, we start the examination by assessing sensation. First, by simply touching lightly the anteromedial aspect of the legs, which are innervated by L4. Do you feel any difference when I do this?
No.
Then the web space between the first and second toes, which is L5. And finally, the lateral aspect of the foot, which is S1. So no difference between the two sites.
No.
Following this, a very good test to screen for L5 weakness is testing the extensor hallucis longus, which is innervated strictly by L5. So you just extend your big toes and you resist me. Excellent. This is a far better test than what we did before, which consists of walking on your heels, which will only pick up significant weakness. This one will pick up much more subtle weakness. When this is done, we do the straight leg raising test, which consists of elevating the leg as much as possible. Now, in a patient with a radiculopathy of either L5 or S1, what you will expect to see is a reproduction of the pain in the patient's leg, anywhere between 30 and 70 degrees. If the pain is felt only in the back, this is considered as a non-specific response. Now, if the pain is reproduced but only after 70 degrees of elevation of the leg, this could be due to a radiculopathy, but very often this can only reflect the presence of hamstring tightening. Now, when the patient has a positive straight leg raising test, say at 45 degrees, what you can do is when the pain starts to be reproduced, let's say in this position of about 45 degrees, then you lower the leg by about 10 to 15 degrees, which should relieve the pain, but then you do dorsiflexion of the ankle, which will reproduce again the pain and confirm that this is a true positive test. The last maneuver that we will do when the patient is supine is to examine his hip joints. Now remember that in patients with hip pathology, the first movement usually to be affected is internal rotation. So in doing this, I may cause pain in the groin, in the buttock, or over the anteromedial aspect of the thigh. External rotation usually is not as good a movement to assess as internal rotation. So we should do that on both legs. So can you now come over on your stomach? And I'll put the pillow under your stomach. So in the prone position, we will palpate the spinous processes starting at L5, remembering that patients will often have tenderness at this level, which is usually nonspecific. What we're really looking at is as we go up the lumbar vertebra is for significant pain that could reflect either a fracture or the presence of infection or tumor. Following palpation of these spinous processes, we will ask the patient to squeeze his buttocks very hard, which is a very good test of S1, remembering that the gluteus maximus are innervated by S1. So in a patient with an S1 radiculopathy, what you may see is loss of tonus on the affected buttock. Finally, in a patient in whom you suspect an upper lumbar radiculopathy, that is of L3 or L4, you may want to complete the examination by doing a femoral stretch test. So the way to do it is to flex the knee to 90 degrees and then to passively extend the hip to about 10 to 15 degrees. So in a patient with an L4 radiculopathy, what this maneuver will do is to reproduce pain over the anterior aspect of the thigh or the anteromedial aspect of the leg. Any other response, including pain felt in the back, is considered as non-specific. So this is the end of the examination. You may sit up. And thank you very much.